next paper will be presented by Dr. SATHOS and is on gastric pacing for the treatment of refractory gastroparesis in children from the Rocky Mountain Hospital for Sick Children. Please.
Thank you, Dr. Diefenbach, Dr. Martin. I also wanted to, before I start, congratulate again my co-author on this paper, Dr. Stephen Rothenberg, on his award. I hadn't had a chance to do that. We're talking today about gastric electric stimulation in children. I don't have any financial disclosures. Gastroparesis in children is and associated symptoms are quite uncommon, only 4.6 per 10,000, with a 5-to-1 female-to-male ratio. The causes are numerous. Idiopathic causes comprise up to half of all cases. Predominant symptoms, as everyone knows, are nausea, vomiting, early satiety, postprandial fullness, bloating, abdominal pain, and rarely weight loss. Typical treatments have always included prokinetic agents and less commonly surgery. However, prokinetic agents have recently become much less used due to multiple problems associated with several of them, and then also the non-availability in the United States. Surgical approaches have been shown in the past to not be as effective in multiple patients, and in the ones that it does work, oftentimes there's other complications possibly. We studied at our hospital in Denver 12 patients so far. Initially, temporary gastric pacing wires were placed endoscopically either nasally or through gastrostomy button. They were attached to the Entera therapy device seen here on the small video, and the electric stimulation was initiated. The patients ranged from 5 years to 18 years of age. Smallest was 35 kilos, and the largest was adult-sized. If symptoms improved significantly and the patient remained symptom-free after the temporary pacer was placed, then permanent surgical placement was done by Dr. Rothenberg 2 to 3 weeks later. As you can see in the top picture here, this is a cardiac lead wire placed down through the nose through a therapeutic endoscope. Once it was attached to the gastric mucosa, then endo clips were used to attach this further to the mucosa to prevent it from falling off in that 2 to 3 week time frame. A second lead was then placed just proximal to this. This is the pylorus off in this direction. So these were anywhere from 8 to 9 centimeters from the pylorus up on the greater curve of the stomach. It was then attached to the Entera device, and stimulation was started. Our results, as you can see, we showed that there was a significant improvement in nausea, early satiety, and vomiting, and then the overall symptom index. There was very high p-values on frequency and severity of all symptoms that were measured. A measuring scale was used. Questionnaires were asked of the patients at pre-placement of the gastric stimulator, 1 month and 4 month. We're planning on doing a 1-year follow-up on all patients as well. Almost all the patients have gotten a repeat endoscopy to make sure that there are no other complications from the lead wire placement when it was done on the permanent placements. The patients that have failed temporary placement had virtually no other costs or expense or sequelae other than a standard endoscopy. So we feel that temporary gastric electric stimulation is easily accomplished using cardiac pacemaker wires adapted for endoscopic use, and then a decision for implanting a permanent pacer is based on the patient's response. Thank you.
Thank you very much.